Good morning. My name is Dr. Kenneth Sharp. I am a foot and ankle specialist, better known as a podiatrist. What I'm trying to do this morning in this short video is to help to teach, explain, and train to the Borrego medical assistants the importance of a diabetic quick foot exam from your perspective, why it's so important, and how to do it, and show you at the end that it takes literally 1 minute to do this. So that's kind of the conclusion, that's the summary. Let's start from the beginning and talk a little bit about what a podiatrist is and what we see and why the importance of our examinations are so important to a diabetic patient. I am a podiatrist for 44 years. I had a full-time practice up in Northern California for 35 years before I moved down here. I work independently in different offices, and I've been the podiatrist in the El Cajon Clinic for the last 8 years. The training for a podiatrist is one of 4 years of college, 4 years of podiatric medical school, and 3 years of residency to include medicine and surgery. So we are the experts when it comes to any and all foot and ankle problems. Most of what we do comprises of treating a problem that's already there, but in a perfect world, in all of medicine, we'd like to prevent the problem to begin with. And diabetics are the prime example of that. What we normally do as podiatrists is take care of corrections like bunions, hammer toes, ingrown toenails, warts, heel spurs. We take care of ingrown toenails primarily on kids, on infants. They toe in, they toe out, they have foreign bodies, they have warts and lesions. As podiatrists, we take care of all ages, from infants to geriatrics. My youngest patient was a 3-year-old baby that came out with an ingrown toenail. So we take care of the whole gamut. Most of our younger diabetic patients are type 1 diabetics requiring insulin. Most of our older patients are more type 2 diabetics taking oral medications. The purpose of what we try to do with our diabetic patients is to prevent an ulcer and to prevent an amputation. So I'm going to leave you with a couple of statistics which are just horrible. In the United States, approximately 22.5 million patients are diabetic. The total cost to treat these diabetics on a yearly basis is $245 billion, that's billion dollars per year. Unfortunately, 25% of all diabetic patients, statistically in the United States, 25% in their lifetime will develop a foot ulcer. So again, the key is to prevent the ulcer, because once an ulcer occurs, statistically, approximately 5% of those patients will have an amputation, which is terrible when it can be prevented. To make matters worse, once one foot or leg is amputated, there is approximately a 80% chance that a future second amputation will be required. And to make that statistic even more horrifying, 50% of patients after their first amputation will die within 5 years. So the key again is to prevent the first ulcer and amputation from happening. To treat diabetic foot ulcers on a yearly basis, the cost is approximately $9 to $13 billion per year. So in our limited clinic here, we're just trying to help lower those statistics and lower the cost factor by prevention. Let's talk for a minute about why people with diabetes have problems as opposed to a non-diabetic patient. Basically, there's 3 reasons why a diabetic is more prone to problems. Number 1 is their whole cardiovascular system gets affected, and systemic-wise, other parts of their body can be affected as well. Their eyes, their kidneys, but their circulation is probably the prime that gets affected. And that affects us because feet normally have the worst circulation on the body, even on a young healthy patient. On an older diabetic patient, their circulation gets even more affected. Number two, and number two maybe should be number one because it's the most important, is the majority of diabetics have what's called a diabetic neuropathy. Neuropathy means that there's a loss of protective sensation. When you touch a hot stove with your finger, you pull your hand away instinctively. Reflexes do that because you feel it hot, you pull your hand away. If somebody drops a hammer on your toe, you know it hurts because you have sensations in your foot. If you have a neuropathy, you have no feeling. And that's terrible because you don't know when there's a problem. So the loss of protective sensation, LOPS, is the biggest predictor of a future ulcer on a diabetic patient. And we'll explain in a minute how you can test for that. Number three, for reasons that no one really understands, people who have diabetes are slower to heal and are more prone to infections. But primarily they're slower to heal once they get a problem. Whether it's an ulcer, whether it's an ingrown toenail, whether it's an infection, they just don't heal as fast. No one really knows why, but that's the way it is. So again, we want to prevent the problem to begin with. So we talked about the whys. Now let's talk about, from a medical assistant's point of view, what can you do? What's expected, from my opinion, is you want to help your primary doctor in checking the person's foot. The problem with all doctors, especially in a place like Borrego, is that there is a high volume of patients coming in. Each doctor has to see a lot of patients per hour, per day, and their priority, justifiably so, has to be on taking care of their main complaint. It might be a checkup on their heart, might be a checkup on their general diabetes, might be a checkup on shortness of breath. So their primary concern is in treating that problem. The problem is that as a diabetic, if they're a diabetic, their feet also needs to be examined and addressed, and they just run out of time. So what the medical assistant's job is to help bridge that gap, and takes 1 minute to do this. So what do? What should a medical assistant do? And we have our patient, Miriam, who's going to help me. So Miriam, let's go ahead and, first of all, what the medical assistant should do is to take the patient's shoes off, help them, or in your case you can take your own shoes off. So you're going to take your shoes off and your socks off. Now this may seem kind of ironic, but many doctors, when treating a patient, a diabetic patient, won't even have them take their shoes and socks off. So the medical assistant's job is to make sure their shoes and socks are off. The medical assistant should also take about a 10-second look at their shoes to make sure that they're not worn out, there's no holes in them, there's no blood on the inside from an infection or an ulcer that the person doesn't know. But basically it's also checking to see the kind of shoes that they're wearing. A diabetic should be wearing a laced type of shoe for protection. A loafer is okay, but we want to make sure that there's no irritations. A loafer sometimes fits too snug. Diabetics should never walk barefooted. Diabetics should not use a pair of sandals or the open thongs except for going to the beach where they want to protect their feet. They should never walk barefooted, especially when it's 100 degrees out, because they may not feel the hot surface of the floor. When they take their shoes off, there's any red marks, lifting the chair up here, as soon as they take their shoes off, there should be no red marks caused by the shoe. In this case, there's not. If there's any red marks, that means that the shoe is either too tight or the wrong size. What the medical assistant should next do is take a quick look. You don't even need to wear gloves. You're just more looking than touching to make sure that there's no lesions on the bottom of the foot. The patient can see the top of their foot, usually, unless their eyes are that bad, but they can't see the bottom of their foot. So your job is to look at the bottom of the foot to make sure there's no lesions. A lesion is a corn, it's a callus, it's a wart, it's a growth, it's anything. It could be a piece of dirt, it could be a twig in there, and ultimately we want to make sure there's no ulcers, an open ulcer on the bottom of the foot. Diabetics don't know they have a problem on the bottom of their foot, so you have to check for that. And if I can take this from you. This instrument right here is called a Symes-Weinstein 5.07 monofilament. This is the greatest thing in testing and evaluating a diabetic patient. It takes 10 seconds to do this. It's a small wire monofilament that bends on 7 grams of pressure. And what that means is that when you push it in and it bends, you see it bend, you should be able, the patient should be able to feel it. So what we do is we start out on the top of the foot, on the lower leg, and we ask the patient if they can feel it. If they can't feel it here, they're not going to feel it further down on their foot because the nerves get worse as it goes down the bottom of the foot. So they should feel it here. And you are feeling that? Okay. Assuming they feel it there, then there's 5 or 6 areas per foot that we want to test this with. So we start on the bottom, underneath the first metatarsal head, that's like the bunion area on the bottom, and we push in. Can you feel that? And then we go on the third metatarsal head, and they should feel that. Normally we ask them to close their eyes so they don't cheat, and we just ask them if they feel something. And are you feeling that, Miriam? Okay. And then we do the same thing on the right foot. So there's 3 areas on the bottom of each foot. And then we also take the monofilament and put it at the end of the big toe. You should feel it there, and you should feel it there. This monofilament is the greatest predictor of a future ulcer. So if there's one thing that you do, it's to use the monofilament. Every patient on every visit should have this done. Again, it literally takes 10 seconds to do. At the same time, as a medical assistant, what you should also be looking for before or after you do that monofilament is to look at the person's toenails. Most diabetics have these horrendous, thick, green, horrible looking toenails that need to be taken care of. They should not be going to a pedicurist. They should not be trimming it themselves. They should not be having their family do it. Even though they mean well, if it's done improperly, that's one of the more common reasons and causes to get an ingrown toenail. Again, then you have to treat the ingrown toenail with antibiotics and surgery on an already poor circulation, immunocompromised patient. So the foot doctor should be trimming their nails. The medical assistant can look to make sure that there's no infection, no redness, no ingrown toenails. They should look to see if the ankles are swollen. I check their circulation. There's 2 pulses, the dorsalis pedis pulse on the top and the posterior tibial pulse on the inside portion. The medical assistants don't need to do that. I'll do that. But if there's any bluish discoloration at the end of the toe, that means that there's a circulatory problem. If the ankles are swollen, that means there's a cardiovascular problem. It needs to be addressed. So the medical assistant should be doing that. Any indication for a problem should then be transferred to the primary doctor, or the primary doctor should then be alerted to refer the person to the podiatrist. Statistically, a person should be seen twice per year for an evaluation on their feet. Talk about a diabetic patient. The Diabetic Association, Medical Association, Public Health, Podiatry Association all recommends that twice per year visit. Medicare, as the guideline for insurance companies, recommends and allows, pays for 2 separate foot evaluations on a diabetic. And from a treatment point of view, if there's an ulcer, if there's a problem, then treatment needs to be as often as needed. From a preventative point of view, we recommend patients seeing us with neuropathy every 2 months. Insurances pay for that. It's a preventative treatment, and it will hopefully keep people out of the statistics for the ulcers. So in summary, medical assistant's job is to act as that bridge between the patient and the doctor and the podiatrist. Having amputations, having ulcers is a horrendous thing to go through. It's a quality of life issue, it's an expense, it's an emotion, and again, 50% of people who have an amputation die within 5 years. If you can help prevent one person with what you're doing, you've done your job, and if you can get them to me so I can do my job, the patient is for the better. Hopefully this will work, answers any questions you might have had, and I look forward to any questions you might have in person down the line after seeing this video. Thank you for your time and patience.